Hello everyone. As a continuation to the chapter Dysmenorrhea and Disorders of Menstrual Cycle, in this video we are going to study about the premenstrual tension. It is also called as premenstrual syndrome. What are the causes and clinical features of it? Premenstrual syndrome is a psychoneurotic endocrine disorder of unknown etiology, which means we do not know the cause of it. It is basically with the it's all with the brain and the endocrines. Psychoneurotic endocrine disorder of unknown etiology. It is often noticed just prior to menstruation, as the name itself signifies premenstrual, which means prior to menstruation. There is cyclic appearance of large number of symptoms during the last 7 to 10 days of the menstrual cycle, which means cyclic appearance. Again and again, every cycle, the same large number of symptoms are appearing 7 to 10 days during the last 7 to 10 days of the menstrual cycle. It should fulfill the following criteria given by ACOG to be termed as a premenstrual syndrome. It should not be related to any organic lesion. Regularly occurs during the luteal phase of each ovulatory menstrual cycle. There are different phases of the menstrual cycle, like proliferative, luteal, and so on. But the premenstrual tension, it occurs mainly during the luteal phase of every ovulatory menstrual cycle. Only then it forms as it is a premenstrual syndrome. That is the criteria for it. Symptoms must be severe enough to disturb the lifestyle of a woman, or she requires medical help. Symptoms must be that severe that it is hampering her day-to-day activities. She is requiring a medicinal help, which means she needs to take some tablets or something to carry on the activities. Symptom-free period during the rest of the cycle, which means once the menses are over, the intermenstrual period should be symptom-free. When these symptoms disturb the daily functioning, they are grouped under the name premenstrual dysphoric disorder, PM premenstrual, DD dysphoric disorder. When they are disturbing her day-to-day activities, this is known as premenstrual dysphoric disorder. Exact cause is not known, but following hypotheses are postulated. We do not know the exact pathology or exact cause what's happening here, but there are some theories which have been postulated, suggesting that this could be the possible reason for the premenstrual tension. Now let us see what are those. Alteration in the level of estrogen and progesterone. Either there is altered estrogen-progesterone ratio or diminished progesterone level. Either of the thing, if there is estrogen-progesterone ratio is disturbed, or if the progesterone is lowered, the level of progesterone is lowered, then it could be a cause. Neuroendocrine factors, the serotonin, endorphins, alpha-amino butyric acid. Serotonin, it is an important neurotransmitter in central nervous system. Neurotransmitter, it transmits the signals in the central nervous system. During luteal phase, decreased synthesis of serotonin is observed in women suffering from premenstrual tension. So, you see that the serotonin levels have been decreased in the women during the menstrual cycle. Endorphins, symptom complex of PMS is thought to be due to the withdrawal of endorphins during the luteal phase. What is happening here? Serotonin levels are decreasing. At the same way, there is withdrawal of endorphins. Alpha-amino butyric acid suppresses the anxiety level in the brain. Along with this, the GABA, alpha-amino butyric acid, is suppressing the anxiety level in the brain of the women. So these are the theories. Either there will be alteration in estrogen-progesterone ratio, or the progesterone level will be low. The serotonin levels will be low, which is observed in the luteal phase in a woman. Endorphins level withdrawal. Alpha-aminobutyric acid, they are suppressing the anxiety level in the women. When you see the psychological and psychosocial factors, that is the environment, how is it affecting the women, it will bring in the behavioral changes in the women. There will be mood swings, she might be angry, confused, and everything. Those all behavioral changes might be observed in a women. Other factors which would be responsible could be the thyrotrophin releasing hormone, prolactin, renin, aldosterone, prostaglandins. Prolactin, renin, prolactin. aldosterone, prostaglandins, TRH, thyrotropin releasing hormone. Now let us see the clinical features of premenstrual syndrome. What could it be? It could be the abdominal bloating. See, if there is water retention, obviously there will be bloating. It will be like edematous. It will be bloating because of the water retention. Abdomen will be bloated. Breast tenderness, swelling of the extremities, weight gain. Whenever the water is retained, the salt and the water's content, there will be disturbance. Edema occurs. Because of edema, what all happens? Abdominal bloating, breast tenderness, swelling extremities, weight gain. Neuropsychiatric symptoms. Think about the effect it causes. Behavioral changes. It acts on the brain. It causes irritability, depression, mood swings, forgetfulness, restlessness, increased appetite. Imagine a patient, she is irritated, she is having mood swings, she is forgetful, sometimes she is depressed, she is restless, she is eating a lot, anxiety about the disease, she is anxious, tension, confusion, headache, anger, tearfulness. At the end, tearfulness. You can just imagine a woman and then premenstrual tension. Think about irritated, depression, mood swing, forgetful, restless, confusion, tension, anxiety, headache and everything. Behavioral symptoms. Fatigue, tiredness, dyspareunia and insomnia. Guys, so the behavioral symptoms, these irritability, depression will come under the neuropsychiatric causes. The behavioral, which means you can see in her, the body will be fatigue, there will be dyspareunia. Dyspareunia, which means there will be painful coitus, tiredness and insomnia, which means the patient cannot sleep. Hope the premenstrual tension is very clear to you guys. Let us summarize it once. There will be, it is a psychoneurotic endocrine disorder, and there will be cyclic appearance of large number of symptoms. The symptoms have been listed here. We went through already. The criteria, it should be during the luteal phase. It should not be related to organic lesion. It should hamper the day-to-day activities of a woman. Then the causes where there is alteration in estrogen, progesterone level might be low, serotonin levels will be low, and the endorphins, they will be withdrawal. During the luteal phase, all this happens. And alpha aminobutyric acid GABA, what does it do? It suppresses the anxiety level. When you see the psychological and psychosocial causes, they will cause the behavioral changes. The behavioral changes we read about: the fatigue, tiredness, dyspareunia and insomnia. Water retention, bloating, the breast will be tender, extremity swollen and weight gain. Neuropsychotic psychiatric symptoms, like we read it twice, so need not summarize. Hope everything is clear. Now let us move on to ovarian dysmenorrhea and the causes for it. Ovarian dysmenorrhea, right ovarian vein syndrome. Each one of the syndrome have its own synonyms, like premenstrual tension was also called as premenstrual syndrome. Like Asherman's is also called as uterine syncope. Same way, right ovarian vein syndrome. Right ovarian vein crosses the ureter at right angle. Guys, imagine the urinary bladder and the ureter. From the kidneys, the ureter is passing, and there is a uterus. The right ovarian vein is crossing the ureter at right angle. During premenstrual period, due to the pelvic congestion or increased blood flow, there may be marked engorgement in the vein. What is happening in ovarian dysmenorrhea? The ovarian vein is undergoing congestion. There is engorgement in the vein. Because of the engorgement in the vein, once it is engorged, there is more blood. It is accumulated. It is putting a pressure on the ureter. With the pressure on the ureter, the urine cannot flow. There will be stasis. Once there is stasis of the urine, it can lead to infection. Then the infection can ascend up and it can cause the pyelonephritis. That is, it can go and infect the nephrons in the kidney. Then it causes pain. This is an important cause of unilateral dysmenorrhea. Same way, like since only the right side of the the right side of the ovary, the right ovarian vein has been affected and putting a pressure on the right side, stasis, and everything is happening. There will be pain only in the one side of the body, the unilateral dysmenorrhea. The causes could be same, some pelvic pathology could be there, that is endometriosis, adenomyosis, pelvic adhesions, uterine fibroid, endometrial polyp, IUCD in utero, that is intrauterine contraceptive devices, chronic pelvic infections, pelvic congestion, cervical stenosis, that is narrowing, obstruction due to Mullerian anomalies. What do you mean by Mullerian anomalies is the Mullerian duct, it could be either bicornuate, there might be a septum in between. Some abnormalities in the Mullerian duct may also cause an obstruction and cause the ovarian dysmenorrhea. Other causes for unilateral dysmenorrhea could be ovarian, this is the end of the ovarian dysmenorrhea. Now we are dealing with unilateral dysmenorrhea. Ovarian dysmenorrhea is a type of a unilateral dysmenorrhea. For the unilateral dysmenorrhea, one cause might be ovarian dysmenorrhea. Apart from that, there will be bicornuate uterus, small fibroid polyp near one cornua of the uterus. If there is a fibroid or a polyp near the one cornua of the uterus, unilateral location of pelvic endometriosis, colonic spasms. If all these things are there, there will be unilateral dysmenorrhea. Guys, ovarian dysmenorrhea might be very clear to you. Who is paying the price here? The ovarian vein is paying the price. There will which is crossing the ureter at the right angle. It will there is engorgement. It is putting a pressure on the ureter. There is stasis of the urine. It is leading to infection, pyelonephritis, and pain. The cause could be underlying any pelvic pathology. You can write adenomyosis, endometriosis, pelvic adhesions, fibroids, polyps, IUCDs in utero, pelvic congestions, pelvic adhesions, cervical stenosis, and so on. Then we read about the unilateral dysmenorrhea, that is painful menstruation, but the pain is only on one side of the uterus, that is either right side or the left side. What could be the causes for it? It could be ovarian dysmenorrhea, bicornuate uterus, small fibroid polyp, unilateral location of the pelvic endometriosis, and colonic spasm. Hope it is clear. Next we'll be learning about MITTELSHMERZS syndrome and SHEEHANS syndrome. MITTELSHMERZS syndrome and its causes. Ovular pain is not an infrequent complaint. See the synonym again here for MITTELSHMERZS syndrome. They can also question you like ovarian pain, ovular pain. Sorry, ovular pain is not an infrequent complaint, which means this is not rare. It is found more frequently. It appears in the mid-menstrual period. During the mid-menstrual period, this ovular pain is found. Pain is usually situated in the hypogastrium or in either of iliac fossa. So the iliac fossas, either of the iliac fossa, the pain could be present, or the hypogastrium. Pain is usually located on one side, depending upon the side of the ovary is ovulating, and does not change from side to side. See guys, the pain, it is located on one side. If it is located on the left side, it will be on the left side only. May the left side is ovulating or not, irrespective of it, whichever side it may be ovulating, it is not related to it. It is present only on one side, depending upon the side of the ovary is ovulating, and does not change from side to side. Nausea or vomiting is conspicuously absent, so no systemic discomfort in ovular pain. The patient does not complain of any nausea or vomiting. It rarely lasts more than 12 hours. The ovular pain will hardly last for 12 hours. It may be associated with slight vaginal bleeding or excessive mucoid vaginal discharge. What happens in ovular pain? Slight vaginal bleeding or excessive mucoid vaginal discharge is seen. Hope ovular pain or MITTELSHMERZS syndrome is clear. You need to remember that the pain will be in the hypogastrium and then it is in either in the iliac fossa. Then the pain is present in the mid-menstrual period. Then it is in the one side and it does not change its side. Systemic discomforts are not found. It lasts for 12 hours. And along with it, there is a slight vaginal bleeding or excessive mucoid vaginal discharge. Now you see the causes for it. Increase the tension of Graafian follicle just prior to rupture. The follicles are undergoing multiplication, and then primary follicle, secondary follicle, then reaches to the Graafian follicle. Once it reaches to the Graafian follicle, there is an increased tension because it has to rupture now. When there is an increased tension, it leads to ovular pain. Peritoneal irritation by the follicular fluid following ovulation. Once there is rupture and the Graafian follicle is out into the peritoneum before it is captured again by the fallopian tube, the fluid will be spilled into the peritoneum, which will cause the irritation of the peritoneum. Contraction of the tubes and the uterus. That could also be a cause for the ovular pain. Define SHEEHANS syndrome and mention its causes. SHEEHANS syndrome, there is a history of severe postpartum hemorrhage after delivery, hemorrhages after delivery, postpartum hemorrhage, shock and severe infection. Depending upon the degree of the anterior pituitary necrosis, the features vary. So guys, in SHEEHANS syndrome, the poor pituitary gland, there is death of the cells of the pituitary gland, necrosis. The blood supply, there might be ischemia and then complete cut blood supply, which is leading to the death of the cells of the pituitary gland, of the anterior pituitary gland. Depending upon how much degree there is a death of the or the necrosis of the pituitary gland, the features of the SHEEHANS syndrome will vary. The common manifestations are, the person with SHEEHANS syndrome will fail lactation. She cannot breastfeed her baby. Loss of pubic and axillary hair. Lethargy. She's too lazy. She's so fatigued that's making her lethargic. Hypotension, secondary amenorrhea, which means secondary amenorrhea, absence of menstruation. Atrophy of breast and genitalia. The breast reduce in size as well as the genitals also reduce in size. So the manifestations will be the patient cannot breastfeed, absent of lactation, and then they do not have pubic or axillary hair. She is lethargic, hypotension, secondary amenorrhea, and atrophy of breast and genitalia. Gonadotrophin level is low, so as to T3, T4, and cortisol. Along with the gonadotrophin levels, LH-FSH, the T3, T4, and cortisol levels, all four things are low. Gonadotrophin, T3, T4, cortisols are low. The hormones affected in order of frequency are, in SHEEHANS syndrome, there is a frequency, there is an order in which the hormones are affected. Growth hormone, prolactin hormone, the gonadotrophins, that is FSH and LH, TSH, thyroid stimulating hormone, and adrenocorticotropic hormone. Hyponatremia may be present, that is, reduced sodium level in the body might be present in 30% cases. Syndrome may develop slowly over 8 to 10 years of time. It is not like it is not a acute case. It is a slowly developing chronic case from 8 to 10 years of time. Guys, I hope SHEEHANS syndrome is clear to you. There is it is occurring. There will be, when you see a person with SHEEHANS syndrome, there will be a history of severe postpartum hemorrhage, shock, and infection. And there is pituitary necrosis of that is anterior pituitary necrosis, and the symptoms will be no lactation, no pubic axillary hair, lethargy, hypotension, secondary amenorrhea, atrophy of breast and genitalia. The what all levels will be low? Four things: gonadotrophins, T3, T4, and cortisol will be low. The hormones which will be affected are gonadotrophins, prolactin, along with that growth hormone. Hyponatremia will be present, and the syndrome will be developing slowly in 8 to 10 years. With this, we come to an end of dysmenorrhea and disorders of menstrual cycle. I hope all the topics are clear. If you have any doubts pertaining to any topic, I ask you to put it down in the comment box. I would try to clear up your doubts. Thank you, everyone.